Welcome back to part two of Informatics in Radiology as part of our podcast for non-interpretive skills in radiology. My name is Nadia Kedem. I'm joined by Elias Kikano. So let's get right back to it. Another aspect of imaging that's related to technology is the topic of data privacy and security. In another podcast, we talked about research and de-identification and HIPAA compliance. But that specifically also applies to the use of images. So when we copy images over for a talk or a manuscript or to share on social media, we have to be careful not to share anything from which patient identifiers can be derived. That is in the metadata that you mentioned earlier. So each image has a kind of hidden data set that can include the patient's name, date of birth, medical record number, all these kinds of things. What's the difference between de-identification and anonymization, and how can we apply that?
Yeah, so you touched on it that there's data that's hidden in this metadata in DICOM images that you wouldn't necessarily remove through routine practice, even so it requires a little bit of a specialized process. You have de-identification, which is just removing the protected health information that is defined in HIPAA, and there's actually specific defined things that qualify as PHI under HIPAA. But the de-identified images may not necessarily fully, stop someone associating those images back to a specific individual. For example, you could change the MRNs that are there to a randomized set of MRNs, but then someone might have a key that they could further identify the patient later. And that may be necessary for certain research projects, clinical trials, things like that. So that's one process. True anonymization is a little bit different because you not only have to get rid of that metadata, not have a key to re-identify it, but then you also take it a step further that there's no way for the images to be reattached or associated with the original patient. And sometimes there's certain things you don't think about. Our ultrasound machines, those are static images. Sometimes those machines have burned in PHI information. So someone has to go in and manually block out the PHI information that's burned into those images. And then other things you might not think about is you have a CT or an MRI or other cross-sectional imaging of the head. With 3D reconstruction now, you can find out a person's face. And so that can lead you to identify the patients. Those are challenging. There's certain tools out there that let you deform some of that data so that it couldn't be identified, but it still may work for your specific use case. But there are all certain considerations you have to take when dealing with the protected health information.
Yeah, and I want to talk about that a little bit more. I know many years ago, I discovered that when you take an image from PACS into a PowerPoint presentation and then you crop out the patient's name, that is not necessarily protected because the cropped out image information could still be in that PowerPoint. So there is another step you would have to do to completely remove it. What I started doing is now we have the screenshot functions on every workstation. So I just take a screenshot and I leave out any patient information, and that's safe. But I wanted to ask you, when you export an image from PACS to your desktop, does it automatically anonymize, or is that also a setting where you have to choose specifically to save it in an anonymized fashion?
Typically, it's an added setting and it depends on how you're saving it. If you're saving it as a static image, usually if that image doesn't have anything burned into it and it's saving as like a traditional image file that's used by like an image you would take on your phone camera, those are usually okay as long as there's no burned in information. But if you're exporting the full DICOM information, you have to remember there's all the metadata that's attached there. And some of the PAC systems or other tools, when you choose that specific function to export, they'll typically have a checkbox that lets you identify that you want these anonymized as an export. And it'll go through its anonymization algorithm to try to strip as much metadata as it can. But you'll definitely want to follow whatever policies that your own hospital system sets in place, because for ensuring the data integrity, some allow individual physicians to have that functionality, but a lot of others will have that centralized so that there's a standardized process for exporting it.
Okay. I guess the screenshot is still a good option.
That's a good workaround.
Yeah, report text can also be de-identified, but that's more of a manual thing. Just delete whatever patient information is in there. And then we already talked about cybersecurity, which I think there is no solution for a ransom attack, right? I think you can't catch these guys. You just have to pay the ransom and move on. Is that correct?
It's challenging, yeah. So ransomware, it essentially means that we use encryption for good things for the hospital, meaning we encrypt all the storage machines that we have and the connections that we have to ensure outside actors can't just look at the information that's being transmitted or stored. And your institution keeps that encryption key on file and owns that. Ransomware is the opposite, where an outside actor comes in and encrypts the drives and doesn't give you the key. So they lock you out of the system. And unfortunately, it's what is normally used for good, it's used for bad, meaning you don't have access to those systems and you could lose that data. And you worry about that spreading to different endpoints and deeper in the system. It's challenging and it's impacted not just healthcare, government systems, power utility systems. You'll hear news about it all the time across the world. So you really have to have good policies in place and try to prevent it, but then also have those business continuity policies of how you're going to operate if that does happen, moving again to like paper orders or things that are outside of the system until you can unplug all those compromised systems from the rest of your enterprise. And then eventually you'll have to reconcile what data was lost and what was missed between the two things between that time period. So it's a challenge for sure.
Yeah, and they enter the system sometimes or maybe always through email, right? When you open some unknown attachment, that could be it. Is that correct?
That's one vector, but there's certainly others. If there's physical access, it can happen. Some of them can be just remotely through other means. There's human engineering tactics. Unfortunately, they'll reverse engineer someone's login credentials if they haven't have a higher level of security and then can escalate from there. We've also seen it interestingly from other systems, from like I said, third-party vendors. They may have a ransomware attack on their systems, doesn't affect the actual ones on the hospital or your enterprise systems, but because they are compromised, then your workflows
Oh, I see.
are in trouble, especially now with things moving into the cloud and doing more things in a decentralized manner and offloading your workflows to other third-party vendors. That's always an increasing liability.
Okay, great. And then before we talk about artificial intelligence, just a few words about image post-processing. There's all these things, there's like 3Ds and MIPS and MPRs and segmentation. Multiplanar reformats are just like coronal, axial, and sagittal scrollable views of something. The maximum intensity projections are a 3D view that is typical a tumble. So you can look at it from all sides as you scroll through and tumble it sideways or up and down. And then the 3D gives you like a full contour appearance of the data set. So you're looking at the surface data, like the facial reconstruction, you can see someone's face. And segmentation is when you're looking for particular tissue types, like you can segment out bone, for example, for CT angiogram, so you only see the vessels. Or sometimes for research, we want to see gray matter versus white matter. So whenever you subtract one tissue type from the images, that would be considered segmentation. And then there is different ways of registering images. There is like a rigid translation, there is a sharing type of thing, and an elastic deformation. Do you know anything about those things?
A little bit, yeah. So there's different definitions. Yeah, when you're basically aligning all the images, like you already said, rigid means like translation scaling. There's affine, which is a shearing. And then there's elastic deformation, which is like warping an image to better align with the target and reference image. There's different ways that you would do this. It could be for patient positioning, soft tissue shapes, things like that. So it's in your toolkit that you can use on most modern PAC stations, and some things are done directly on the modality, like you're saying for head imaging, how they align the head to be in the correct position. That's one format of it. If you have patients changing positions on the table, you could realign your angles to go through the appropriate planes to get the right diagnosis. We do that for rectal imaging for MRI to make sure that the plane is correct to find the rectal tumor, other things like that.
Okay, great. And then there's curved reformats, which is something I do often in facial imaging to see the anatomy of the teeth or a fracture. things like that. So that's pretty straightforward. Artificial intelligence, I think this is a new chapter in the syllabus, and I'm glad they added it. There are different terms. There's artificial intelligence, machine learning, deep learning. What is the difference between those three terms?
Yeah, so it's a new hot topic and it's been around for a little while, but definitely worth getting some knowledge around and wrapping your head around it because these are being rapidly deployed at different levels all throughout the system and the radiology workflow. So artificial intelligence is that broad definition that's using computers to simulate human intelligence. That's a broad overarching term, could mean many different things in many different areas. Subset of that is the machine learning that is basically using the computers to learn a task on their own without set instructions. Before we used to have, and we still use like rule-based functions that where you can tell a computer, if this happens, then do this and follow this set of actions. Machine learning kind of flips that and says, we'll give a bunch of data to the computer and let it figure out what to do next without explicitly giving it the instructions. Deep learning is another subset of that, which is using these multi-layered neural networks with some connections between them to look at a bunch of data and essentially can be done with whatever data you give it. It can be text, images, a combination of that. But again, to have that unsupervised learning, and then you go into those different definitions about the algorithm behind it, whether it's a supervised or unsupervised process.
Okay, yeah, talking about that, what is the difference between supervised and unsupervised?
Yeah, so supervise it. You essentially start with a labeled set of training data, meaning in imaging, for example, it might be going through a set of chest x-rays and explicitly labeling what is normal, what is not, and having all of that outlined by humans first, giving that to the computer and having the algorithm essentially evaluate how well it's able to predict things on a new set of data once it's learned from that supervised set. In that process, you don't want any overlap between your training data and what you're going to expose it to so that you try to minimize some of the bias that's there. You use an unsupervised set, meaning you can give the computer and algorithm a set of data that is not necessarily labeled or structured and allow the unsupervised model to essentially figure it out itself. That has its own drawbacks as well because they might need further training or more data basically to figure out what's actually correct and not. So balancing those supervised versus unsupervised learning in the right context is really important.
Yeah, labeling data is extremely time consuming, but it is the best way to actually make sure that the model learns the correct definition or identification of the data set. I heard that some early AIs were based on images that they took from Google, like anything that was available on Google. I really question the labeling or the correctness of that input and then the output, that AI model. I wouldn't trust it at all. But I have a question for you. So you've probably seen this picture where it says the AI can't differentiate between the face of a chihuahua and a muffin. And then they show these things together and it looks really similar, the big eyes of the
Yeah.
chihuahua and the muffins. Is that related to supervised or unsupervised learning, or why can the AI not tell the difference?
It can be. So it depends on the training data exactly that went into the algorithm and how much is there and what the basis of it is. And yeah, you'll see different scenarios like that where the mistakes are very obvious to a human, but the computer is using some sort of association that it made with the data that it was trained on. And that's why it requires multiple layers of refinement. Another good example is it can make associations that we wouldn't think of. I've seen examples where you want it to figure out which images are of a wolf or an animal, some sort of animal. And so it turned out after analysis, it's picking them out not because it sees the context of the actual animal and its characteristics like we would, but it notices that almost all the pictures that it was trained on in the background, there's some snow. So it learns to make that association based off of the environment in the background, not the actual animal that you wanted to identify. And same thing for good or for bad, that happens with radiology images and things like that. It's going to make connections based off of the entirety of the data that it's given rather than what we may see with our visible eyes or are trained to look for. So there's pros and cons of each of those, but really the key is understanding how the training was done on these models and understanding what their flaws are, and then being able to monitor them post deployment to make sure that there's no drift or bias and that they're still reporting of ground truth.
So that takes me to another question I have, because there's this idea of a black box model. So what you just said to me is not a black box, because you can go back and see why the AI put out a result, and you can identify what it used to come to the conclusion and it was the wrong thing. But in a black box, in my understanding is you can't figure that out. Is that my correct understanding?
Yeah, so that's a general term that's used, exactly that, when you don't know what the actual connections are that the algorithm or the model is doing. Most places are trying to move away from that model because you wouldn't want to deploy something in healthcare that you couldn't then validate why it's making the predictions that it is, especially if it's doing that in some automated fashion or having direct patient care scenarios. I know at our institution, while we can't necessarily change models from outside third-party vendors because that's their whole thing, at least we require them to provide us with data post-deployment to be able to track any differences or variations in how often it's making predictions. If for some reason it's identifying positive cases in a higher frequency than it was a week ago. What changed? Was it something from the institution? Is it change from the algorithm or something else where the model is drifting or making changes? We make that a requirement to be able to follow up on that. And while you might not know, you may not be able to know exactly what or why is happening, although you can get into that detail a lot of times. We at least do that post monitoring to make sure that we keep things in check.
Great. Then another application that I'm really excited about is the natural language processing, because that can do so much for quality improvement. For example, these applications can read the radiologist's report and can see if there's a critical finding in there, whether something needs to be marked for lesion monitoring, for follow-up imaging, whether the follow-up recommendation was compliant with practice requirements, and can even also generate radiology pathology correlations. So I think that's really fantastic that we can do that.
Yes.
We talked a little bit about the black box already, and are there some other deployment challenges? I think most people have some sort of AI working for them now, but not as much as we wish for.
Yeah, we're not going to get replaced anytime soon. There's no concerns there, but certainly you're going to see, even at our own institution, we've started having some AI models that are helping to ease our workflow burden and add additional context to provide more timely care for patients and bring up findings that we may have missed to just bring attention to them at the very least. And this can take multiple shapes and forms, whether it's directly on the imaging data or workflow management, anything in between. Things that we already talked about is that making sure that you follow up and monitor any of that data drift to make sure that the performance of the model is staying within the boundaries of what the expectations would be. And then making sure that the workflow is correct for radiologists and other staff members so that there's still a human essentially in the loop of any interventions that are being made or predictions that are being made.
Yeah, so that is a question I've brought up with some of these people who are big proponents of AI algorithm, the data drift monitoring. Is that something that the users should do or that the vendors should do? Do we trust the vendors to do that correctly? Are their standards as high as our standards? And if we do it, what are our rules? What's the medical legal liability? None of this is really resolved, or is it?
I think it's too soon these things are so new that there's still some uncertainty around it, as you said. There are certain societies that, like the ACR and others, that are putting some practice guidelines in place and general recommendations that institutions and groups should follow. And certainly there's state and federal mandates coming down the pipeline that could influence all this. But I think a good practice is for, at least for individual radiologists and trainees, to be aware of all of these definitions, be having a basic understanding of what these mean, so that when they go into practice, they try to understand why a certain AI in a certain workflow is doing what it's saying it's doing, and have a certain sense of skepticism if something is off, and always use your clinical judgment to stay in the loop, because we're all stakeholders in this. Like you said, the vendor may have different interests. The individual radiologist has different interests, operations, and business continuity groups or business leaders will have different considerations. So you want to have all stakeholders involved and following these AI models as they get more and more prolific throughout the practice.
And then lastly, I think there's bias in every AI because it's based on human input, and human input is biased, but there is specifically also statistical bias, such as sampling bias, which refers to the data set that might be used to train the AI. It could be a specific population that is not inclusive, or could be specific to a certain geography and doesn't readily apply to other populations. Great. I think we went through everything, and you're such an expert. I'm so glad you answered all my questions. There were a lot of things I didn't know. So thank you so much, Elias.
Of
And you
course.
have a good
Happy to be
day.
here.
Thank you.
Thank you so much.